Good evening, everyone. My name is Deanna Kalala. I am the chair of the community committee for the NODCC, and I'm really thrilled to be here tonight on our latest edition of the Connect and Reflect series. Tonight, we're going to be talking about understanding neuropsychological assessments or neuropsych evals for children with disorders of the corpus callosum. And I am thrilled to be joined by Dr. Ono here as well to talk with us tonight. So if this is your first Connect and Reflect, just so you know the flow, I'll give an intro of Dr. Ono, and then she's going to share a presentation with us outlining the basics of neuropsych evals, and then we'll open it up for moderated questions at the end. So be active in the chat, send your questions on the chat or the Q&A, and I will mark them down and make sure that I ask Dr. Ono when we open up for questions as well. So without further ado, I will read a brief introduction for Dr. Ono. Dr. Ono completed her education and training as a child clinical psychologist at the University of Miami in Coral Gables, Florida. She completed her internship and fellowship in clinical neuropsychology at Emory University, School of Medicine and Children's Healthcare of Atlanta, which is CHOA. She continued her career as a senior neuropsychologist at CHOA for 8 years thereafter. She is a board-certified clinical neuropsychologist by the American Board of Clinical Neuropsychology. Dr. Ono's research and clinical interests are in congenital brain disorders, epilepsy, neurofibromatosis type 1, learning disabilities, attention disorders, autism, and concussions. Her love of working with families and providing individualized services for children have led her into private practice. So she's got her own practice as well, and hopefully we can hear about that a little bit too. But Dr. Ono, thank you so much for being here with us tonight.
Thank you for having me.
Yeah, my pleasure, my pleasure. So I'm going to get out of your way and get off the screen, and I'll turn it over to you so you can give us an overview of neuropsychological assessments. And thank you so much.
Share my screen. All right, can everybody see that okay? Okay, so stop me if you cannot hear me or cannot see the screen up. I'm just going to kind of jump into it, talking about neuropsych assessments or neuropsychological evaluations. I kind of titled this Pediatric Neuropsychology. However, I do both adults and pediatrics now in my private practice. I'm actually doing PRN or part-time neuropsych evaluations in adults mostly. So you can have these types of tests kind of across the lifespan. Neuropsychologists are generally trained developmental lifespan because all adults were kids at one point. And so we like to understand how the brain develops from infancy all the way through adulthood. Just an agenda for tonight. I'm going to go in through some introductions and special interests. We're going to discuss neuropsychological or neuropsychology and the evaluation, assessment domains and tests, and neurocognitive profile for disorders of the corpus callosum. So what is a pediatric neuropsychologist, or what is a neuropsychologist? This is a subspecialty of psychology that focuses on changes in thinking and behavior, and it's usually secondary to a type of disease or a medical condition that affects brain health. And there's a lot of things that affect brain health, and I'll get into that in a second. We use standardized testing and behavior observation to understand a child or an adult or a teen's strengths and weaknesses. We call this a neurocognitive profile. And I'll go through the different aspects of an assessment in a little while, so you'll see where this all plays together. And the neuropsychologist often participates in research with medical teams. And so as Mrs. Kalala had mentioned that I participate a lot in research with neurodevelopmental disorders as well as epilepsy and concussion. A lot of neuropsychologists like to participate in research just to make sure that that's always at the forefront of our assessment. So we want to make sure that our tests are always valid and we're keeping up to speed on what is the newest in the research fields. So what is a neuropsychologist? Usually, well, always, they have a doctorate degree. There's different types of psychology degrees. There's PsyDs or PhDs. It usually is about 5 years of graduate school work and a 1 year of clinical internship. A neuropsychologist has extra training than other psychology fields, and so we have a 2-year postdoctorate fellowship in neuropsychology. The clinical practice is usually conducting evaluations, interpreting test results, making recommendations for families in the medical team. And then our research practice usually kind of goes along with our clinical focus. And so in my past, I've done a lot of research in autism. I started off in autism, then I kind of transitioned more to epilepsy and concussion and congenital diseases and all of that. So kind of ebbs and flows with what your interests are clinic-wise. A lot of your research questions are formulated based off of things that you see clinically and vice versa. So they both go hand in hand. So what populations do we serve? So we serve patients that have brain injuries. So this ranges from mild TBIs or concussions, car accidents or major traumatic brain injury patients, stroke or near drowning, so anoxic injuries, brain abnormalities, so malformed structures, disorders of the corpus callosum would fall under that area, things like heterotopias or brain abnormalities or lesions within the brain would also be considered in there. Genetic disorders such as NF1 or NF2. Epilepsy is probably the most prominent disorder that we will see. It's the most common neurological of a type case that we would see. Brain tumors or space occupying disorders, cerebral palsy, and things that also affect the brain like heart disease. And so when you think about the brain requires oxygen. And so if the heart or the lungs are not taking in enough oxygen or giving the brain enough oxygen, then you can have some cognitive effects related to other disorders that you might not consider a neurological condition. So lung diseases and heart diseases would also be things that we would see. So in what settings does a neuropsychologist work? So we have outpatient settings such as private practice or medical clinics. We work in hospitals, we work in universities or research institutes as well. What is the neuropsychological evaluation for children or adults? It's similar for both. So essentially what you start with is just a review of the history. We want to know everything about the medical condition, developmental challenges, whether they had developmental milestone delays, family history. So is there a family history of any types of genetic disorders, learning problems, psychological problems, which may affect the child's profile, and school challenges or vocational difficulties. So are they falling behind academically for certain reasons in certain areas, or are they having struggles at work in certain areas? We want to focus our assessments to help best serve the patient and their family. And I'll get into why you would want a neuropsychological evaluation in a little while. But these are all really important things for us to understand the profile of an individual. It includes an observation during the evaluation. So it's not only the test results, but it's also the things that we observe or that we see. So we call these qualitative and quantitative. So the quantitative would be the test results. The qualitative would be, how did they do this? So when we're talking about fine motor skills, not only is it important for us to know that their standard score was significantly below what we would expect, but what were they actually doing? Were they turning the pegs a little interesting? Were they turning their heads? Were they not able to place the pegs because of visual spatial challenges? There's a lot of different reasons why a person would either fail or do poorly on different assessments. And so the qualitative assessment is it's just as or more important than just the numbers, the quantitative results. We put together all these things after the testing in a written report with results and recommendations. Sometimes most of the times, the recommendations are the most important thing. So I will skip through a lot of the testing. I will go through any diagnoses that we will give the individual, but then we really spend a lot of time on the recommendations, because the recommendations are our interpretation of the results and how can they be helpful for this person or their family. Let's say a child has or a person has challenges with learning in a certain way. They learn a different way. We want to make sure that we have the recommendations that will serve this person to help them in school, or whether it's at work or something like that. So the recommendations are kind of the key part of the assessment. We apply knowledge of the child's history to understand the results. So as I mentioned, the developmental history and the family history are really important. Not only is just the medical history, because we call it that neurocognitive profile. So it's this whole profile of all these different things and how we piece them together to understand the child's strengths and the weaknesses. We often provide feedback to the families and the medical team about concerns. And so sometimes if we see something that is a little bit concerning in a certain area, we may ask the family or the medical team to take another look at maybe they need extra brain imaging, or they need to have another consultation with their neurologist or their pediatrician regarding medication management because of some of the things that we see in their profile. So those are all things that we look at. So what is assessed in a neuropsychological evaluation? It's very broad. We cover everything from intellectual functioning. So these are IQ tests, academic or achievement testing. So this is how well you do in school, or these can also be things that affect your work, like reading tests. Executive functioning skills, and this is probably the area that most people are interested in because this term is kind of thrown out there, executive functioning. I'm sure all of you have probably heard of that term and may or may not understand it very well, but it is this umbrella term that we characterize a lot of different planning, organization, flexibility, your ability to monitor your emotions and your behavior, initiation, novel problem solving. We think about multitasking falls within that executive functioning bucket. And that is a skill that we call kind of higher order. That's one of the skills that develops all into your 20s. And so, especially for kids, we don't expect them to have great ability to control their behaviors and their emotions, which is why you might see a 5-year-old throw themselves on the ground and have a tantrum. That's perfectly age appropriate. But if you see a 20-year-old doing that, that may be a little bit questionable. But those skills develop all the way into your 20s. And those are the kind of those skills that, if kids are doing fine in elementary school and when they're younger, if they have executive functioning challenges, those are the things that we see later on coming online as problems, mainly because as school is formulated, they also know that children aren't expected to have great executive functioning skills. So in kindergarten and first grade and second grade, you don't have a lot of independence. Starting in third grade, and this is where we usually see this shift, where some of our kids start to fall behind, is in third grade. And that's when those executive functioning skills start to play come into play a little bit more. The independence is a little bit more. It's also that shift where they're not learning to read, they're reading to learn. And so we always tell parents third grade is kind of that key year. Attention problems, which also fall within that executive functioning bucket, are also an area of attention for us. This includes challenges with focus and hyperactivity. As a neuropsychologist, we can give diagnoses. So we can give an ADHD diagnosis or learning disability diagnoses. Pediatricians are also able to give ADHD diagnoses, but they're not permit. I think some do, but they're not supposed to be giving learning disability diagnosis. You'll need a formal evaluation for a learning disability. We assess for learning and memory challenges. So this is both visual, spatial, and verbal learning and memory, language challenges, visual, spatial challenges. So this is your understanding of the world around you. It's your understanding of perceptual reasoning, puzzles, pattern construction, all of that kind of fall within that visual, spatial bucket. Fine motor skills, as I mentioned, so this is your ability to move your hands. Behavior and emotion functioning, which is also really important for us. So we want to know how they're functioning with their behavior, not only within our setting, but within the school setting or their work setting or their home environment, all of those things. And so oftentimes we'll have parents complete or the teen or the adult complete questionnaires about how they're functioning outside of our one setting. We call a neuropsych evaluation kind of a snapshot because this is just our one glimpse of how they're doing on that one day. There's a lot of things that impact that. Did they get good night's sleep before that? Did they eat a good breakfast? Are they tired? Did they forget to take their medication that morning? All these things can contribute to how they perform that one day. So we want to make sure that we kind of tap into some other aspects of their life as well to see if this is something that we see in other domains. So do we see this behavior outside of our testing environment? Do we see it in the classroom? Do we see it at home? All of those things too. And social skills. Social skills are really important. And especially for disorders of the corpus callosum, social skills are one of those areas that are often affected just by the location of where the corpus callosum is and what its function is. So I'm going to go into each domain just briefly. So on IQ evaluation, everybody knows what that term is. There's different tests that we use to assess them. The gold standard really, and it varies by age, but for kind of teens and adults, it would be the WAIS, which would be the Wechsler Adult Intellectual Scale. For children, it would be the Wechsler Intellectual Scale for Children. There's different variations of that. There's something called a WASI, which are also kind of that Wechsler name. And those are the gold standards for about kind of 6 years old and up for assessing intellectual functioning. For younger than that, there are a few things that we use for infants and really younger kids. We use something called the Bailey. There's also something called the DOS and the RIOS, and those are all different types of intellectual functioning assessments. But in general, they assess the same things. They always have a verbal component because understanding language, your expressive and receptive language skills are all part of your IQ. They assess nonverbal areas as well. And then let me caveat the intellectual functioning assessment. We do have some intellectual functioning assessments that are for nonverbal individuals. So we can get a nonverbal index as well for an IQ score for individuals that are nonverbal. And those are things like the P-TONY or the TONY are some of those assessments that do that. We also assess spatial indices. So this is your ability to construct designs, use blocks to make patterns. Working memory, or how much you can hold and manipulate in your head, is also usually part of that index. And processing speed, or how quickly you can process information, whether it's visual, spatial, or verbal information, how quickly you can kind of process all of those. And we collect all of these indices to form a full-scale IQ or an FSIQ, and that is what we usually interpret for those results. This is probably going to be in too much detail, but all scores are standardized. So we take the raw score that your child or the adult performs, and we standardize it based off of their age. A lot of times for the adults, they standardize it with age, education, and gender sometimes even, to formulate a standard score. And based off the standard score, we can say if based off of this score, are they performing above or below where we would expect the general population to be performing? And that's how we formulate strengths or weaknesses. And so usually it's about one standard deviation above the norm is considered a strength, and one standard deviation below the norm is considered a weakness. And the areas of weakness are the areas that we want to highlight for the recommendation section. And the areas of strength we also want to highlight too, because you want to take into account the person's strengths to play off of some of those weaknesses. In general, most people have strengths and weaknesses. Everybody has strengths and weaknesses. So we want to take those strengths to help them with those areas that are a little bit weaker for them. The other thing that you might see in evaluations is something called a normative versus a relative strength or weakness. So a normative strength would be compared to the normative sample. They are performing above expectation, whereas a relative strength would be compared to themselves. So if I were a high average individual, a score that's average would be below where I would my other scores would be falling. So that would be a relative weakness. So compared to myself, that is a relative weakness. However, compared to everybody else in the normative sample, that's average. And that's still kind of a strength compared to the general population. So language skills. So receptive language skills and expressive language skills. And so everybody probably understands this. So receptive is your ability to understand information. This is one-step, two-step commands. This is your ability to hold information and be able to understand and process that. Expressive language is confrontation naming. It's your ability to name pictures, or what is this? It's your ability to express yourself, or verbal reasoning skills, your ability to understand how two things are alike or the same, or how to describe something. So one of the assessments that we have is tell me what a pen is, and they have to tell us what a pen is, and they have to describe it with words. We sometimes, for some of the younger kids, they have a hard time with this, so we have to pretend. Pretend we're an alien. We just landed on this earth, and you have to tell us what soap is, because they use it every day, and so it's hard for them to describe what it is, because the answer we usually get is it's soap. It's what you use, and we're like, well, describe it more. Pretend like we have no idea what this is, and we just landed on this earth, and this is something that we see and we don't know what it is. Tell us about it. So you have to get into a little bit creative sometimes with pulling out the information for them to describe some of the things. Oh, visual, spatial, and perceptual skills. So there's different aspects of this. This is just a picture. It shows kind of visual discrimination. So which of these is the same? Which of these is different? You have to look in detail and be able to find which of these things are alike or the same. A lot of times you have those puzzle books where it's kind of that like hide and seek, where you try and find a little apple that's hidden in a big puzzle or something like that. Those are also kind of more kind of visual spatial reasoning, visual spatial tasks too. Puzzles would also fall in that visual spatial domain. Visual construction tasks. So as I was mentioning, using blocks to make it look like a picture, or tangrams. I'm not sure if you guys are familiar with that, but my kids love them. They're little designs or pieces of a puzzle that you have to make into a pattern to make it look like a cat or something like that. Those are all kind of visual construction tasks. Visual reasoning tasks. So they might show a picture of a little seed, then a little sapling, and then a little tiny tree. And then what is next? You want to say like a bigger tree, they want to see some reasoning skills related to the things that they see. That's visual perception and visual reasoning skills. Fine motor skills. So there's different tasks that we use for this. In this picture, it shows a Ravma and a grooved pegboard. So this Ravma pegboard on the left-hand side is just a pegboard that we ask the kids or the adults to place the pegs in, and we time them to see how many they can do in a certain amount of time. We do it for right hand and left hand. And then one next to it is called a groove pegboard, which some of you might have seen before. This is a task where we have them. It's kind of like a key. There's a rounded edge and a square edge on these little pegs, and they have to rotate it with their fingers and place them into the little holes and see how many they can do, or we time them and see how long it takes them to put all those little pegs. And you can see on that little board that the little notch kind of rotates. So they have to rotate the peg around. This gives us a really good understanding of, are they able to place the pegs? We also want to see how many times they drop the pegs, or are they turning their whole body when they're trying to place the pegs in the holes. And so those are when those qualitative skills really kick into some of the importance for those fine motor skills. Executive functioning or reasoning skills. So these are some games that use problem solving or executive functioning skills. We tell parents that board games and games in general are a wonderful way to boost a lot of cognitive skills. And so you don't even realize it probably, but a lot of the games, there's that battleship game, chess is wonderful, checkers is a really good game for strategy. Card games are wonderful too, not only for fine motor skills. Holding those cards in your hands are not easy. My kids use card holders, but holding the cards helps with fine motor skills, in addition to the fact that a lot of card games use strategy. And so strategy, anything when you hear the word strategy, that's executive functioning. Anything with kind of problem solving, or you need to plan and organize, that is executive functioning. Initiation time. So sometimes when you tell your child, okay, can you go clean your room? And they can't do it. And you're like, why didn't they do it? And you get mad at them. It may not be that they don't want to. It may just be that they don't know where to start. And so you have to break things down for them. Kids that have problems with executive functioning skills are the individuals that they want to do it. They just don't know where to begin. It's such a big task. So we need to break things down for them. Rule violations. And so this is, my kids have this as a problem with the rule violations in some of the games, but rule violations are also fall within that executive functioning domain. We keep track of some of the assessments that we do on how many times they break the rules. It's not because they're trying to cheat. It is because they either forget the rules or they can't figure out another way around it. So sometimes rule violations aren't on purpose. And then the number of attempts to complete tasks, or how long will it take you to complete a task? Yeah, Johnny was able to do the task, but it took him 90 minutes and 500 moves. That is a lot of tries. It was trial and error. He didn't have a plan for it. He was just kind of going which way and whatnot. He didn't have a strategy. And so that is also an indication of problems with executive functioning. Accuracy of solution. Yeah, Johnny took 500 moves to finish this problem. He got to the end, but his accuracy was very poor. So all those things are really important with executive functioning. So deconstructing, and finding the impact of concerns. And so all these different things may affect different aspects of a person. So if a person has attention problems and hyperactivity, They might have problems with reading, mainly because their comprehension is low and their reading accuracy is poor because they're not able to pay attention to that. It can affect your math skills, so they make careless errors or inconsistent performance. It may impact social problems, so they may not have that ability to be self-aware and that they need to control their emotions in kind of around their peers. And so they might be kind of rude or say awkward things or be immature. It affects their emotional functioning too. So these individuals or these children are self-aware, that they understand that maybe their friends are not playing with them as much, and that's because they are annoying or their friends interpret them as being annoying. So this may cause some anxiety or mood problems. They may have poor frustration tolerance or poor self-control, and they might be easily overstimulated and sensory seeking because of those attention problems. Their memory might be impacted too because they might be more forgetful or have poor retention. So you can see how one problem can affect all these different areas of an individual. So what the evaluation results can tell us. So if a test results are inconsistent with a medical diagnosis and developmental history. So sometimes, actually, oftentimes we see that the challenges are not related to the diagnosis. So in research, this is why everyone does research in neuropsychology. It's because they have these profiles. So we know that epilepsy is associated with executive functioning and attention problems. There's an overlap about 50%. There are 40 to 50% of individuals with epilepsy end up having a diagnosis of ADHD. But maybe that's not what we see. We see that they just have learning problems and their attention is perfectly fine. So that is something that we want to understand a little bit better. Maybe it's because they have a family history of learning problems. Other things can contribute to that. And so that's why we want to collect a good history of the individual too. We want to find out whether a child meets criteria for a clinical diagnosis. So I mentioned a few of the diagnoses that are common for us. ADHD, or attention deficit hyperactivity disorder, and that name gives it a lot of people think that hyperactivity is always subsumed within that ADHD diagnosis, and that's not true. That's just the new terminology. It used to be ADD, or attention deficit disorder. Don't know why they changed it to ADHD. But there's 3 different subtypes. So there's predominantly inattentive, there's predominantly hyperactive, which I never see, and then there's the combined presentation, which is inattentive and hyperactive. And so with the ADHD diagnosis, we always have to give the extra subset, whether it's predominantly certain inattention, hyperactive and inattentive, or just hyperactive. Another diagnosis that we often see is autism, or autism spectrum disorder. And so those are some of the common clinical diagnoses that we would diagnose based off of our results. And any impairments may be higher than expected for medical, developmental, or family history, and whether these need medical follow-up. So I was mentioning before whether we see certain types of profiles. So we all know that the brain controls different functions of your behavior and your body movement. Sometimes we see that things line up. Meaning that a child or an adult has a very kind of left hemisphere profile, meaning that a lot of the functions that are associated with that left hemisphere are impacted on the test that we see. So the left hemisphere, we think of language. In most of the people, even left-handers, your language is housed in your left hemisphere. If that, in addition to contralateral fine motor functioning, so your right hand, if we see impairments in language and fine motor skills in your right hand, as well as verbal learning and memory challenges, we call that a very left profile individual. We normally don't see things that are very in contrast. So we don't normally see a big split like that is all in one hemisphere, unless there is something that's very lesional or a traumatic brain injury or something that affects that specific side on the brain. If we do see something like that, then that is concerning for us if it doesn't match up with their medical diagnosis, because there might be something there. Maybe they're coming into us because they had a concussion, which is a very generalized neurological disorder, but we see this very profiled case. Then we might ask them, maybe we should get an MRI because something's not matching up for us. We want to also make sure that we get a good history, like have they always had problems with their verbal skills or their receptive language skills, because maybe they were just born like that. As I mentioned, everybody has strengths and weaknesses. So maybe they're just always better at visual spatial skills and verbal skills. And then we also want to know whether a child needs intervention and school services. So there's different things, and I can go into detail if people are interested in that, about the different services that we can request for schools to accommodate with. In public school, individuals can receive something called a 504 plan or an IEP. I always call the 504 plan or Section 504 plan the baby IEP, or the IEP is an individualized education program. The 504 plan is usually for individuals that needs lesser support. So if a child just has ADHD, but their intellectual functioning is average and they are performing fairly well academically, they just need some accommodations with their environmental changes, then a 504 plan would be sufficient for that. However, if they need any therapies, so if they need language, so speech and language therapy, physical therapy, or occupational therapy in school, or if they need extra supports in certain areas, tutoring, things like that, then we would be requesting the more advanced form of recommendations or school services under that individualized education program. So those are all listed in our recommendation section too, and we go through that with parents and individuals, whether those are some of the things that we want the schools to implement, because the IEP needs, there's a whole process to getting an IEP in place. And we are more than happy to talk with the schools about getting those things in place, because we are really excited about getting the services for our kids that they need. And neuropsych testing results are better at predicting function than an MRI of the brain. And this is mainly because what is a neuropsych test? But it is a behavioral assessment of their function. So these are better at understanding where a child is. So oftentimes you'll be surprised at some of the brains that we see and how they're functioning, because you can have actually one hemisphere completely removed and the person is talking and walking and moving, and you wouldn't expect that based off of their MRI results. But behaviorally, the brain is this miraculous thing that adapts and will migrate functions to other parts of the brain so that they can preserve what we call the eloquent regions. So the eloquent things are language and motor skills, and the brain is going to try and preserve those things in function. So differences of corpus callosum abnormalities. And so as you all know, there's different types of disorders of the corpus callosum. There's kind of a complete agenesis, which would mean that the front, middle, and back sections are all either missing or malformed. Partial agenesis, which is only parts of them are missing. You can also have different things that affect the corpus callosum, so like hypoplasia. All of these things that would affect the corpus callosum. And you can also have abnormalities of the corpus callosum due to external disorders such as hydrocephalus. Just based off of where the corpus callosum is in the brain and the deep structure and where the ventricles are, hydrocephalus is a disorder where the ventricles are not able to remove the liquid, the kind of the cerebrospinal fluid from the brain, and so they can impact that corpus callosum. So there's different things that can affect the corpus callosum. And what does that have on the importance of a individual with disorders of the corpus callosum? You see a whole vast range of functioning. You see some people that are greatly impacted, so that have intellectual disabilities, to individuals that are very high functioning. And so because of that, there is not one profile that we think of with the disorders of the corpus callosum. Some of the things that we might see are problems with cognitive problems with reading facial expressions or voice tone, difficulties with executive functioning, problem solving, assessing risk, abstract concept understanding, and difficulty understanding emotions. These all sound similar to a diagnosis of autism, and so there is some overlap with autism as well. Developmental characteristics, sometimes you see delayed in motor skills, such as walking and crawling, delayed fine motor skills, so poor coordination with your hands. Maybe you're late to learn to tie your shoes, poor penmanship, all of those things. Delayed toilet training. And then social and behavior characteristics include kind of social immaturity, sometimes the lack of self-awareness, difficulty understanding social cues, hyperactivity. So sometimes we see this ADHD diagnosis, obsessive or compulsive disorders, and then a lack of fear. And so those are some very broad kind of characteristics. And as I mentioned, disorders of the corpus callosum they range so much in functioning. Thank you. I ran through that really quick. I'm happy to answer any questions.
That was amazing. Thank you so much for really breaking that down. I think in a way that whether you've had a neuropsych eval before or not, like you know what to expect and why they're doing it. And I think, you even got into a lot of detail about some of the specific testing, which I think is really helpful for people as they interpret their own neuropsych evaluation. So thank you so much for that overview. I've got some questions, but also if you have questions, feel free to put them in the chat. The chat's been chatting throughout your presentation with lots of good reflections. So you guys put any questions you have in the chat. And I will start with the first question, just about how do you find these neuropsych evals? So you mentioned that they're at hospitals, they're at universities. What's your best first step to find the right neuropsych eval?
Yeah, so hopefully your neurologist or pediatrician will be able to locate you somebody that can do a neuropsych evaluation. There is something called psychologytoday.com, which is a link that you can click on and find local psychologists in your area that take your insurance. Most neuropsych evals are covered for any type of neurological condition. So if you have a neurological condition, then insurance will normally pay for it. So that is wonderful news.
And then someone asked, how often should you have a neuropsych eval? And maybe an added question is, when should you start as well?
So it's never too early to start, I think. The neuropsychologist will generally tell you when they want to follow up with you. So after the evaluation, they'll say, hey, I'd like to see you in 1 to 2 years or 2 to 3 years based off of the results. Mainly, we base them off of how they're doing at that moment in time. The other thing too is if you see a big change in your child or your behavior, or your functioning, then you might be like, oh, I need to get an updated evaluation because something's different, something's not going right. Or if I had a really hard year at school, maybe you want to have an updated evaluation sooner rather than later.
And is it common for parents to kind of direct also how often they like to have it? Like some people want more information than others.
Yeah, absolutely. We're more than happy to see. So you can't have one more than once a year. Because of just how the tests are developed, it would breach kind of test security for us if and some of the tests don't have kind of retest reliability within a year. So we can't see them more than once a year, but we can see them up to 1 to, sometimes we say 3 years out is when we want to see them. We might pick certain times of the year too. So if we see them in kindergarten, we might say, hey, I want to see them again before they start third grade, something like that too.
And one of the questions gets into the nitty gritty of insurance. And I'm sure you've seen all of this from being, with CHOA and also, now being in private practice. There are some concerns with getting insurance to cover a neuropsych eval, right? And so can you give any tips on how to communicate the needs to insurance so that they will
Yeah.
cover it?
Yep. So there's something called a CPT code. I actually don't know what it stands for, but however,
Don't worry, we
those
don't
are going to
either.
be those are going to be the most important things for you to do. What I would do is I would call your insurance or actually call the neuropsychologist ahead of time and say, hey, which CPT codes do you use? And which ICD-10 code would I fall under? So those are the two things that they would need or you would need to provide to the insurance company. Then call your insurance company and be like, hey, I would need a neuropsych evaluation for myself or my daughter, my son. This is the ICD-10 code that they're going to code under, and these are the CPT codes that they're going to use. Would I be covered? So those are the things that those two things are you're gonna need. And
And if they push back and say, no, you're not covered, like, can you convince them? Or I know
I would
there's,
try. I would
uh-huh.
try because I mean, most insurances should cover them. Um, the type of insurance varies on, I know that there's certain like Cigna's a little bit harder sometimes to get them covered with certain things. There are certain insurance companies that are harder to get the evaluation covered by them. At the bare minimum, I've had families, even if the child didn't have a neurological condition, have them be able to use it towards a deductible. So at the
Okay.
minimum, that's what you can
Yeah.
ask for.
Okay. So there's some wiggle room in there if they're not
Yeah.
looking to cover the whole thing.
Yeah.
And then, so say you get your CPT and ICD-10 codes, whatever that stands for, and now you've got a list of neuropsychologists to choose from. How do you decide what is the right fit for you? Who's going to provide you with a quality exam?
I would ask them if they have expertise or they've ever worked with an individual with a disorder of corpus callosum. That's going to be the most important thing. And then secondly, if you find someone that's board certified, those are generally individuals that have done extra training to get those extra letters at the end of their name.
Mhm.
Those are individuals that have kind of passed this board certification. Those are also going to be the individuals that you kind of want to seek out too. You want to find somebody that is a true neuropsychologist, so has training, those kind of 2 extra years of fellowship in neuropsychology. I've I'm from Hawaii and I've seen people in Hawaii say they're neuropsychologists, and you look at their training, you're like, how are you a neuropsychologist? You didn't get that training to be a
Uh-huh.
neuropsychologist. So they would never be able to be board certified, because to be board certified, you have to have met certain criteria to be able to even apply to take the really, really awful exam that they have to make you do.
Yeah.
Um, but you want to make sure that they have training in neuropsychology, because understanding the brain development is the most important thing, especially for a type of assessment like this.
Yeah. Okay. So we find the doctor, get to the appointment, or maybe this is before you get to the appointment. You talked a little bit about, how sleep or their medications or all sorts of things can affect their performance of their neuropsych eval. Do you have any advice on how parents can prepare their children for the process and support them through the process as well? I know it can be quite time consuming as well.
It is. It takes a long time. It depends on the child's age, but the older they are, it can take up to 4 to 6 hours. The littler ones, you'll probably be done in 2 to 3 hours, but it's a long day. It also depends on if the person has ADHD or attention problems, and we need to take lots of breaks. We might even break it up into 2 days and have them come back another day, because we want to make sure that we get their best effort. So if we need to break it up into 2 days, we'll be like, I'm sorry, but we couldn't finish everything. Can you come back another day or
Mhm.
another time? Um, so you want to make sure that they get good sleep the night before, if possible, whether this is knocking your child out, and I've done this before where my kid needed to get to bed, and melatonin is a wonder. So we call them night night chewies.
Cute.
So knock your child out if you need to, get them to get to sleep on time, having a good breakfast. They'll usually take, well, they'll always take breaks throughout the testing day. So bring a lot of snacks with you, water, something to, if they like to do work on the iPad or play games, something when they're taking their breaks to help calm them down, especially if a lot of our kids have anxiety or test anxiety. And this is a really big test per se. A lot of times the neuropsychologist won't call it a test, we'll call it a game or a puzzle or something like that. That's more fun. But sometimes we want to just make sure that during their break time, they're able to relax, and give us their best effort when they're working with us.
Okay. And then once they get to the point where, they've got the results back from their psychological evaluation, how does that assessment guide the IEP individualized intervention planning process and or additional support services? I know you mentioned you could go into more detail with that, and I'm sure people on this call definitely would love to hear that.
Yeah, so most of the times, and this I'm saying in my reports, I always put like as the first thing, if a child needs a 504 plan or an IEP, that is our first recommendation, because that's the most important thing. We want to make sure that we include all of the recommendations that we want to see in the IEP or the 504 plan. So we list it out. There's no question on what things we want to see put into those plans for the child, written out for you. We'll go over those in detail. The other thing that I like to mention to parents is that we call it our wish list. So I put in a whole lot more than what schools are actually going to give us. And I will highlight for parents and be like, hey, I know this is a long list and school may not, if they do, great, give us all of it. But if they don't, these are the few things that I want you to make sure that you get. I don't care about this one as much, but this one is the most important. So I'll go through the recommendations. We want to make sure everything is written down, so that if school sees it, maybe they'll give us everything. But if not, highlight for parents. I, give them multiple copies of the report when I'm going through the feedback, and say, like, scribble this down. This is the one I really need you to get because this is the most important. For a child with ADHD, there's something called a behavior intervention plan that we can get in school, which is essentially they have a consultant come in, they assess the child, and they put together this behavior plan for the child. That is really, really critical and important. And I will hands down want that more than preferential seating any day. So
Mhm.
if we can get that in the IEP, that's something, or the 504 plan, that's what I would want. So I'll go through those in detail with the families as well. But everything will be written down for them. So you don't have to worry about that. The main thing, and your neuropsychologist will tell you after they go through the recommendations, what your next step is. So be like, hey, all right, so now that you have the recommendations, call your school, ask them to set up an IEP meeting, tell them my child had a neuropsych evaluation, the neuropsychologist is requesting an IEP put in place. Can we get a meeting set up? They'll put a meeting set up and everything like that. You can ask your neuropsychologist to sit into the IEP meeting if they're willing to sit in and kind of discuss some of the results. Usually the school will have a school psychologist that has already looked over the report as well. So that person's also sitting in the IEP meeting. But the neuropsychologist can really advocate for you and your child about all the things that they told you. I really need this behavior plan put in place.
Yeah.
They'll be there to be that second person being like, yeah, this child really needs a behavior plan put in place.
Mhm. And one of the parents asked about the difference between a neuropsych eval and that a private practitioner or doctor would do and what the schools typically do as part of the IEP process. Can you talk a little bit about that?
Yeah, so there is the neuropsych evaluation, which is what a neuropsychologist would do, is much more comprehensive. The psychoeducational evaluation, or you'll find some private practice practitioners that do psychoeducational evaluations. Those are really based off of identifying, they can give a diagnosis of a learning disability, but they also are just focused on kind of academics and IQ. So those are the two main things that they really assess for. In schools, they sometimes add a few other things. I've seen kind of VMIs or visual spatial motor integration tasks, and they'll add a few other things, but they're really tailored to what is affecting the child academically, as opposed to what is affecting the whole child, which is what the neuropsychologist is trying to understand. So that's why we test executive functioning, learning and memory, visual spatial challenges, fine motor skills, all those things that they might not tap into in psychoeducational evaluation.
And then my last question for you is, what's cool in neuropsych evals right now? Like, are there any new emerging trends or technologies that, the field is moving towards at the moment?
I think a lot of it is AI driven. So
Okay.
now we are trying to do a lot of things, especially for memory tasks, because we want to see things that have, we call it ecological validity. So yeah, this child can't remember digits forward and backward or sequence them, but how is that going to pertain to the real world? So a lot of the tests nowadays are tailored towards trying to figure out whether we can create tests that have a lot of ecological validity, or in the real world, how does it map onto it?
Very, very
So that's
interesting. AI is getting everywhere out there.
it is even, I mean, a lot of our, and you'll see this too when you take your child into testing, is we have iPad testing. We're doing everything on the iPads now. It's a lot of it's automated, which is really nice. So scoring errors are going down because we don't have to hand score all these different things. But they're trying to automate a lot of the tests. But as I mentioned, half of what we do is that qualitative assessment. And so
Mhm.
hopefully I will have a job, because they can't get rid of me completely yet, just yet.
Right. We have at least 5 more years before the computer takes all of our jobs, I think. So, well, Dr. Ono, thank you so much for taking the time out to talk with the NODCC community this evening. Everybody, Dr. Ono's contact information is right there on the screen. She's in the Atlanta area and the Hawaii area. So if you find yourself in either of those locales, definitely feel free to reach out. But thank you so much, Dr. Ono. We really appreciate it. This was awesome.
Thank you.
All right. You all have a great evening.